For the first part of the talk, I'm going to talk about atypical and uncommon manifestations of HCC. My colleague, Dr. Nandwana, is going to talk about mimics of HCCs and unusual hepatic lesions. Okay, I'm not going to go into much detail about the background, but I just want to point out HCC is the second most common cause of cancer death in the worldwide, and the numbers are going to actually increase because of the obesity epidemic. Although currently viral hepatitis is a common cause of cirrhosis, it's expected by 2030 NASH will replace it and become the major cause of cirrhosis. And it's very important for radiologists to be familiar with atypical patterns of HCC, what we call LRM with the LIRADs, and understand there are different subcategories, histologic categories of HCC that we might encounter daily. Okay, so you don't have any trouble to identify this as a classic HCC or LIRADS 5 lesion in a background of cirrhosis or chronic liver disease with arterial-enhancing lesion, washout on pseudocapsule. Obviously, you take into account the size, with or without presence of restricted diffusion or intralesional fat. However, the typical imaging characteristics might not be present. And take a look at this case. It's a T2 bright lesion in the left lobe. There's no arterial enhancement on a portovenous phase. There's a rim enhancement, and this is a biopsy-proven, poorly differentiated HCC. The lack of arterial enhancement in this case was presumably due to intratumoral necrosis, which was confirmed on biopsy. Also, in poorly differentiated HCCs, you might encounter cystic changes inside the HCC, which is not very common actually. You see multiple T2 bright foci inside the tumor with intratumoral T1 hyperintensity, presumably hemorrhage, and the enhancement is kind of similar to the prior case. We don't see arterial enhancement, and this might confound the diagnosis, and usually in these cases we try to recommend biopsy because the differential includes also metastases and also other non-HCC malignancies. Not only they can be poorly differentiated, they can actually de-differentiate into different subtypes, and there's a subtype that is well known in pathology literature. It's a sarcomatoid subtype. Again, you see multiple very heterogeneous T2 signal with cystic spaces inside, intratumoral hemorrhage, and progressive nodule peripheral enhancement. We thought this might be an angiosarcoma or some sort of sarcoma met, but this turned out to be a sarcomatoid subtype. On pathology, usually these have spindle cell differentiation, and interestingly, the AFP is low to normal, and they have obviously poor prognosis with higher rate of recurrence and extrahepatic metastasis. This is another case at our institution that this grew in a matter of 2 months. To this size, almost quadrupled in size. It started to invade into adjacent structures, and similar pattern of imaging pattern. And on pathology, they see distinct spindle cells. Cystic features also can be seen in not the differentiated or poorly differentiated HCCs. This was a case of clear cell HCC that, again, kind of similar pattern, but also intralesional fat on out of phase, and this was biopsied, and this turned out to be a clear cell HCC. They might coexist with other subtypes, some similar to fibrolamellar with cystic, but clear cell dedifferentiation or differentiation, and the appearance is presumably related to cytoplasmic accumulation of glycogen or fat, and they usually have better prognosis. You see cytoplasmic clearing. This was actually the same case that was biopsied at our institution. Infiltrative HCC is not a subtype, but it's atypical because you don't quite see the typical enhancement pattern. And looking only at the perfusion looking at the enhancement might be deceiving because there might be actually vascular involvement, as you see in this case with a tumor thrombus in the left portal vein, and the arterial enhancement is usually quite variable. And usually what we recommend is using DWI and good quality T2 weighted imaging to see the extent of tumor. Make sure that you see flow voids in all the vessels, otherwise you might be missing a tumor thrombus. And usually it has a permeative appearance and very heterogeneous washout, as you see in this case. Look at the other case that we had. This was a T2 bright, well-defined lesion with targetoid arterial enhancement and persistent enhancement or delayed enhancement on portovenous phase. This was called a cholangiocarcinoma. This was biopsied, and it turned out to be a serous HCC, and the appearance is usually caused by abundance of the background interstitial space and fibrotic component. As you see these bundles of collagen, and that actually increases interstitial space and delayed enhancement, and tumor cells are interspersed in between these fibrotic background. Again, it's very hard to differentiate this from cholangiocarcinoma or mixed type HCC cholangio, and also metastatic disease, and usually biopsy is mandatory. We talked about a couple of cases that you don't see arterial enhancement because of intratumoral necrosis. This was a case that it was an early HCC that was T1 bright and T2 dark, and it's hard to say on dynamic phase if this is truly arterial enhancing with washout or not, and usually you have to have a very good subtraction, and we didn't have much of misregistration, so we could clearly see there is arterial enhancement and washout in this. And presumably, if you look at the pathology literature during the dysplastic phases of hepatocarcinogenesis, iron starts to accumulate inside these nodules, these dysplastic nodules, and as the nodule turns into an HCC, usually the iron content goes down, and usually you don't see an HCC with T1 hyperintensity. This was an unusual case because sometimes you can see still persistent T1 hyperintensity within an HCC in early phase, and usually that regresses after the patient progresses into the higher grades of HCC. Another type that's not very common, actually it's pretty rare, the only case I've ever seen and has been described in both pathology and radiology literature. This patient had a central mass in the caudate lobe with arterial enhancement and washout, but then there are numerous nodules in the left lobe of the liver. And these are actually discrete HCCs in the background. This was actually the patient had an explantation, liver explant, and these are actually unique individual HCCs, numerous ones, more than like 200, as the report said, but it can go up to thousands. And usually they're we are not able to distinguish them from nodular regeneration and cirrhosis. These are usually moderate to well differentiated HCCs, and usually they're found at explantation after the liver was explanted, and usually have a unique pattern. These are actually probably more advanced in the case that we are seeing. The importance is that you shouldn't call this an intrahepatic metastasis from a dominant mass. Usually these are just multiple individual HCCs. A steatotic subtype of HCC is well described in the pathology literature, and the unique thing about this is usually there's background of NASH and metabolic syndrome. The fat is quite exuberant in this case, and usually is similar to this case. And the amount of fat actually makes it very hard to distinguish from benign lesions such as lipoma, adenoma, and AMLs. We had multiple cases recently in young patients without background cirrhosis. This actually was a case of a patient with cirrhosis, but and biopsy determined that this was a steatohepatic HCC. And usually you can see intravoxel fat within an HCC, but as the HCC progresses into a more advanced stage, it will become, the steatosis will be less and less apparent. This is actually Different from that, this is actually, steatosis is a prominent feature of this tumor, even in the advanced stage, and they can metastasize too. Usually, however, they're more moderately, more well differentiated, and they have a better prognosis. Again, if you're using hepatobiliary agents like gadoxolic acid and you're evaluating a lesion, remember HCCs can show uptake of EOVS in this case, as there is on an out-of-phase imaging, there is intravoxal fat, but the portion of this lesion shows heterogeneous uptake of EOVS. It's been shown that this is related to overexpression of OATP membrane receptors, and the degree of uptake and the degree of expression of this membrane receptor has a reverse correlation with the degree of HCC. So well-differentiated HCCs can show uptake of EOVS. Fibrolamellar HCC, everybody is probably familiar with this subtype. Usually they happen in the younger population without background cirrhosis. The differentiating features are central scar, which is very heterogeneous, and they can have calcification. Sometimes people mistake these with FNH. Obviously, not probably people in this room, but usually the teaching is that the central scar is usually more heterogeneous, T2 dark, and doesn't enhance. But if there's any confusion, obviously we can use EOVS or gadoxolic acid or hepatobiliary phase. I'm going to show you a couple of cases that we missed, was missed and outside hospital. This is another case which presented to us with arterial rim enhancing lesion in the right lobe. It's a little faint lesion, and you see washout. This was called in an outside institution as an HCC. The patient underwent transplantation, and patient presented like 3 months later with multifocal rim enhancing metastasis in the liver. And on an explant, they found that this was a combined HCC cholangio. This is a typical LRM lesion that you see, and we shouldn't call these LR5 lesions because there's a chance that if it's a cholangiocarcinoma or a mixed type, these are rare. Obviously, they have poor prognosis, and usually we have to recommend biopsy. Obviously, because the risk factors for HCC and cholangio is similar, you can have coexisting concurrent HCC and cholangio in the same liver. This is a typical cholangio and HCC at the same time in this liver. Biliary invasion can be seen in HCC. We are seeing not too many of this. Like we have probably 6 or 7 cases that I've personally seen. Usually there are bigger lesions. This was actually problematic in our institution. This was an arterial enhancing lesion with washout, and then there was biliary dilatation. And the question was, is this a mixed lesion or is this a cholangio? And this turned out to be an HCC. It can happen in the setting of HCC. Usually it happens when the lesion is bigger. This was a fibrolamellar HCC with periportal metastatic lymphadenopathy, as you can see here, and then there is marked intrahepatic ductal dilatation. So it can happen. It depends on the location of the tumor, how big it is. And this was quite an unusual case that we saw recently. The patient had 2 years history of treatment for HCC with Y90, and the tumor came back as a recurrence and actually became like an infiltrating lesion. And you can see actually it's completely, replacing, actually invading into the portal vein. There's no flow void, and you can see marked intrahepatic ductal dilatation. We didn't do biopsy at this point, but presumably this was an HCC which was turned into a poorly differentiated HCC with biliary dilatation. Again, in these cases, you have to rule out possibility of cholangiocarcinoma. I'm going to show you a couple of examples of unusual dissemination and metastatic pattern of HCC. In general, HCCs can metastasize via hematogenously and through lymphatics, and also they can actually directly spread into the adjacent organs and peritoneum. This was a case of a subcapsular HCC with numerous peritoneal nodules. And presumably these are related to micro-ruptures into the peritoneal or omental surfaces. If the rupture happens acutely, the patient will come in with shock, and this is a true medical emergency. Fortunately, it doesn't happen that often, but in the literature, up to 1% of HCCs present like this. This was a case of active extravasation from a subcapsular, presumably subcapsular lesion, that like an exophytic lesion with hemoperitoneum. And usually the risk factors for this is a larger size of tumor, increased vascularity, subcapsular location with contour protrusion, trauma. And we have seen this in TACE, but usually they don't present with shock. This was a case that after TACE patient presented with still viable tumor, but some perihepatic T1 hyperintensity, probably old blood. Everybody's familiar with tumor thrombus. With HCC, they can extend into the portal vein, to the IVC. In this case, it's even going into the right renal vein. This is MR for the same patient. Usually poor prognosis. Similar to RCC, when there is tumor thrombus in the IVC, a piece of tumor can slough off and go to the chest and creates this branching tubular pattern that has a very good correlate on CT. This was a treated HCC with some residual tumor. Is actually recurrent tumors extending into the suprahepatic IVC, and then there's a tumor thrombus right there. Similar to RCC, you can see it with HCC as well. And you can, obviously, you need to have an MR to differentiate it and CT to differentiate it from bland thrombosis by subtraction imaging. Adrenal invasion, we had a couple of cases that patient actually was treated, and probably during treatment phase, the nodular portion of the tumor actually extended into the retroperitoneum, and this was a case that actually the recurrence actually involved the adrenal gland. This wasn't, the previous case wasn't actually metastasis. We could see on multiple sequential imaging that it was growing into the adrenal gland. This was a unique case we had, that the patient still has a viable tumor after treatment. The location of the tumor was subcapsular, and the tumor is actually extending into the retroperitoneum and encasing the right kidney. Again, this was an unusual case. It doesn't happen that often, but similar to the peritoneal spread of tumor, you can see retroperitoneal invasion of HCC. Direct extension into the diaphragm usually is problematic when they're treating these patients with TACE, and usually they develop parasitic feeder arteries from the diaphragm, and usually the recurrent tumor is located very adjacent, very close to the diaphragm, close to the bare area of the liver, and you have to be careful. In our institution, usually chest is read by somebody else. I also look at the chest portion of the exam myself, and this was a case. Wasn't read by me, but whoever read it made a very good call that this tumor is actually extending into the right lower lobe bronchi. Patient presented also with hemoptysis, and you can see actually the tumor is extending into the right lower lobe. Biopsy tract seeding can happen with HCC, as you can see in this case. Usually it happens when tumor is poorly differentiated. We use larger size needle. We usually try to not to have too many passes, but if you have too many passes, this can happen. And interestingly, if you're doing biopsies, presumably it's better to have a normal portion of the liver just to avoid seeding and also hemorrhage. But if you just directly go into the tumor, obviously the risk is higher, and biopsy prior to RFA is another cause. Adrenal metastases adrenal is the fourth most common site of HCC metastasis after lung, lymph nodes, and bones. This was quite interesting case. The patient had treated HCC without recurrence, but very big masses on chest CT was seen, and then bilateral adrenal masses with extension into the renal veins. And a few quick examples of like 3 cases that was misdiagnosed in an outside institution. Actually, one of them was in our institution when I was doing my fellowship. This was called a giant hemangioma patient. Was a young patient without cirrhosis, very heterogeneous T2. It was called that a nodular progressive enhancement, but you can agree with me that usually hemorrhage in hemangioma is an atypical feature, and T2 is very abnormal in this case. And this turned out to be fibrolamellar HCC. Unfortunately, the patient came back with multifocal metastases. So always look at your T2, make sure you're assessing the T2 and the heterogeneity should trigger that this might be something else. This was called a foconodular hyperplasia. You agree with me that the degree of heterogeneity in this tumor was very atypical for FNH. Obviously, you can do hepatobiliary phase imaging if there's any doubt. And then this was a young patient without cirrhosis. Again, it was called an adenoma with lesion of fat, arterial enhancement, and washout. And this turned out to be a steatotic type of HCC because this was actually growing. So one of the things you can do if you're not sure, obviously, you can do a short-term follow-up. And with that, I would like to thank you for your attention.
All right, good morning, everybody. Thanks for that talk on atypical HCCs. I'm going to be focusing on unusual hepatic lesions, not HCCs. So we're going to identify uncommon hepatic lesions, describe their cross-sectional imaging characteristics, and discuss diagnostic tricks and potential pitfalls to avoid image misinterpretation using a case-based approach. So here's our first case. It's a young female with no history of malignancy. You can see there's multiple T2 hyperintense lesions, T1 hypointense lesions. They're predominantly subcapsular in location, a little bit of capsular retraction, and on post-contrast imaging, it demonstrates a targetoid or a halo appearance. So at this point, you may be thinking, well, could this be Mets? Could these be abscesses? But this patient's really young. She's got no history of malignancy. She's not acting clinically infected or sick. This is a case of epithelioid endothelioma. And the key point here is that they can mimic cholangiocarcinomas or abscesses or Mets, but they do typically occur in young females. They can coalesce to form larger confluent regions. They can have capsular retraction. And a key point here is that they can demonstrate this lollipop sign where a hepatic or a portal vein branch can terminate right at the edge of these lesions. This is just a quick companion case, shows very similar findings, T2 hyperintense lesions in the subcapsular location that can coalesce, has this target or halo appearance, and again, this was epithelioid hemangioendotheliomas. All right, case number 2. This patient was a status post-liver transplant 2 months ago with rising LFTs. You can see they have multiple lesions. These lesions demonstrate nodular areas of enhancement. At this point, you may be thinking, well, could these be hemangiomas? This would actually turn out to be hepatic angiosarcomas, and the key here is to look for centripetal enhancement, which is more bizarre in shape, or a reverse hemangioma pattern in comparison to hepatic hemangiomas. These are associated with thorotrast, vinyl chloride, arsenic radiation exposure, and interestingly, we have a couple of these cases at Emory, and 2 of them are associated post-liver transplant. So don't know if there's a link there between immunosuppression, but we have seen them in these liver transplant cases. All right, case number 3, this patient presented with abdominal pain. You can see there's this heterogeneously enhancing mass, that's T2 hyperintense. It clearly contains fat on out-of-phase imaging, and this turned out to be a hepatic angiomyolipoma. And the key here is to look for an early draining hepatic vein from the tumor center. This can help differentiate it from an AML from a fat-containing HCC. This companion case here, it shows a large lesion here, multiple flow voids, again, intratumoral fat, and this was a hepatic hemangiolipoma. And here you can also see a classic hemangioma, and it's just nice to show that multiple different types of vascular lesions can exist in the same patient. All right, case 4, this patient presented with nausea, vomiting, and abdominal pain. You can see there's this large solitary lesion in the left hepatic lobe. It demonstrates heterogeneous peripheral and progressive enhancement. And you may be thinking this could be a giant hemangioma. This is actually misdiagnosed at our institution as a giant hemangioma. But the key here is look at the T2 signal, and it has what we call that evil gray T2 signal. And this was a hepatic neuroendocrine tumor, and this actually was a well-defined mass with cystic changes. It had some internal blood products on the pre-contrast MR, and again, look for that evil gray T2 signal. This is a companion case. It looks exactly like that last case I showed you. It was actually another hepatic neuroendocrine tumor, and again, notice that evil T2 gray signal, and these are cystic changes, and this was progressive rim enhancement. And of course, we can get 3 in a row, but this was not a neuroendocrine tumor. This turned out to be an aggressive angiomyxoma of the liver. This is not something you're going to prospectively diagnose. It's extremely rare. lesion that happens, there's only a few case reports. But here again, the key is not to mistake this for a giant hemangioma. Look at that heterogeneous T2 signal. In contrast, this is a giant hemangioma. It's defined as greater than 5 centimeters, and you get that peripheral nodular puddling of contrast, and you should have this homogeneous T2 signal. This case was also a giant hemangioma. While they're benign, obviously, they can need surgery. This patient ended up bleeding into their giant hemangioma. You can see these large T1 hyperintense foci of blood products. They can present with rupture, rapid growth, or even consumption coagulopathy, necessitating this patient had a left hepatectomy. All right, case number 5, we have a T1 hypointense lesion. It's progressively enhancing and persists on delayed imaging. Maybe we're thinking this could be a flash-filling hemangioma. You want to check your T2s, and instead of it being T2 bright, this was T2 dark with flavoids. This was actually a portosystemic shunt. It can occur in chronic liver disease, post-biopsy, can be congenital or spontaneous. Case number 6, here we have multiple T2 hyperintense, T1 hypointense lesions. You can see some of these have intense enhancement, others have kind of peripheral enhancement. They are irregularly shaped. This is a case of hepatic pileosis. And this is a benign disorder, and it's due to multiple blood-filled lacunar spaces. They can be seen in the setting of TB and AIDS. All right, case number 7, again, we have multiple T2 hyperintense lesions, demonstrates arterial enhancement, which persists on delayed imaging. These are also irregularly shaped, and this is a case of HHT, or also Weber-Rendau syndrome. And it's a rare autosomal dominant disease where multiple vascular shunts develop. They can cause high output cardiac failure, portal hypertension, and even biliary disease. All right, case number 8. Here we have this T2 hypointense, maybe isointense lesion. It demonstrates delayed enhancement. It's oblong and shaped, and the key here is to know where is this actually located in the liver. It's centered on the IVC. This is an intrahepatic IVC leiomyosarcoma. These are predominantly in females, and again, the location here is key. This is just a quick companion case. It also shows another IVC leiomyosarcoma growing actually into the middle hepatic vein and turning into a large intrahepatic mass. Companion case of a metastatic leiomyosarcoma, again, you'd have this T2 hypointense signal with a delayed enhancement, but again, you can see the primary leiomyosarcoma in the pelvis. All right, case 9, we have a 55-year-old male with HIV. We have multiple hypodense lesions without significant mass effect. There's extensive RP lymphadenopathy. The vessels appear to be encased and penetrating through rather than occluded. This is a case of hepatic lymphoma. It can be primary or secondary. Primary needs to be confined to the liver and the perihepatic nodes for 6 months within onset of the disease, whereas secondary, you want to look for spleen involvement and generalized lymphadenopathy. Companion case here, multiple T2 hyperintense lesions. They're delayed enhancing, and again, this has splenomegaly and lymphadenopathy, so this actually was secondary hepatic lymphoma. All right, case 10. This patient has changes of chronic liver disease. We see this kind of geographic heterogeneous hypoenhancing area. It has a little bit of T2 spare signal. When we check our in and out phase, we can see that this is actually nodular focal fat or a pseudo-lesion. Make sure you always check your in and out of phase imaging. All right, this is a really interesting case here. We had multiple hepatic lesions here, a little bit T2 hyperintense signal, some delayed and heterogeneous enhancement here. And on in and out of phase imaging, these lesions are containing fat. So you maybe think, oh, is this a pseudo-lesion or is this focal fat? If you look at your diffusion weight in imaging, you can see that these lesions are actually restricting diffusion. And what you don't want to miss is this panc adeno. And this turned out to be biopsy-proven pancreatic metastasis. And, uncommon manifestations of common things like metastases are still more common. So this was actually pancreatic mets. Similarly, in case 12, a 57-year-old female with a history of remote breast cancer, you can see this arterial enhancing mass with washout. Maybe there's a central scar here. There was no changes of background chronic liver disease. people thought, could this be a fibroblastoid HCC? This actually turned out to be a atypical breast metastasis. Again, while most breast metastases are going to be hypoenhancing, you can get uncommon manifestations of metastatic disease. All right, case number 13. This is a really interesting case. This patient had a remote history of sacral chordoma, and he was getting serial chest CTs looking for metastatic disease in the chest. On the bottom of the chest, they saw these two hypodense lesions in 2011. They went back to 2008, and they didn't see it. They thought, oh, maybe it's just due to differences in technique. But let's get an MRI in 2012. These were T2 hyperintense lesions. They said, oh, these are cysts. Follow-up MRI in 2013. Yeah, they're still cysts. They're a little bit bigger. And then in 2014, all of a sudden now you're seeing there's a little bit more of internal complexity, maybe some heterogeneous internal enhancement. These were growing cystic lesions. It took us 3 years before we finally said, hey, these are not cysts, and these actually turned out to be growing chordoma metastasis. So key here is to know what the primary tumor signal characteristics are. The chordoma was T2 hyperintense. Don't assume everything in the liver that's T2 bright are cysts, and compare with priors. That's really, really helpful. All right, case number 14, we have a heterogeneously enhancing mass, we have surrounding perfusion anomaly, and we have central restricted diffusion. You could be thinking, is this a necrotic tumor? This actually turned out to be a hepatic abscess. Here, clinical symptoms really are the most helpful thing, and sometimes necrotic tumors will have peripheral restricted diffusion rather than central, and that'll help differentiate between a necrotic tumor and a hepatic abscess. You guys may have seen this case yesterday at the Jeopardy. This was our hepatic abscesses due to pylophlebitis from a perforated fishbone, and this is just reminding you guys to always look for atypical causes. When you think of hepatic abscesses, you think of diverticulitis, but you also want to look for uncommon causes. This case here, again, was called originally as a hepatic abscess, but if you look closer, this hepatic abscess or cystic lesion was communicating with the pancreatic duct, and this patient had multiple pseudocysts and changes of acute pancreatitis. This actually was an intrahepatic pseudocyst. So key here is to look for communication with the pancreatic duct and a history of pancreatitis. All right, atypical hepatic abscesses. This is just a companion case. We have this complex cystic mass here. There's multiple septations, areas of calcification, and you can see that it's extending beyond the margin of the liver or Glissen's capsule. And this was a case of hepatic fasciola. It's helpful here to know the life cycle of hepatic fasciola. When you ingest this bug, it actually invades through the duodenal wall and then penetrates through the liver externally, and that's why you get this stuff outside of the Glissen's capsule. They can form round and clustered lesions in the parenchymal phase, can cause dilated biliary ducts, and can calcify chronically. The way that you can differentiate this from chlorhydrochloricus sinensis, which is another liver fluke, is that chlorhydrochloricus sinensis actually tunnels up through the biliary tree from the duodenum. It doesn't go through the duodenal wall, and that's associated with RPC. All right, case 15. Here we have a complex cystic lesion, multiple septations with fluid levels. There's minimal septal enhancement. This is our mucinocystic neoplasm of the liver. It always occurs in females. They're lined by ovarian stroma. It has a cyst appearance, usually found in the left hepatic lobe. Majority of these are benign, but 10 to 15% can have malignant transformation, so they do come out. And you want to differentiate these from IPNBs, as there's no communication with the bile duct, and these were formerly known as the biliary cystadenocarcinomas of the liver. All right, last case here, we have a T2 hyperintense lesion. It appears to be communicating with the bile duct, which is dilated downstream. There is no enhancement, and this is a case of an IPNB. These are a precursor to cholangiocarcinoma, so you want to look for enhancing soft tissue and has an older male predominance. This is a companion case that we recently just had at Emory. Again, you can see this large T2 hyperintense lesion. It is communicating with the bile duct tree, which is filled with mucin and therefore dilated. And this lesion actually does have some abnormal enhancing soft tissue, was resected, and it turned out to be an IPNB with high-grade dysplasia involving the left hepatic duct. So in conclusion, there's lots of atypical lesions to keep in mind, but many have radiographic features that can suggest the diagnosis, and these are the ones that we had covered. So thank you very much.
Do we have time for questions?
Yeah, we have time.
First of all, congratulations on 2 speakers. Lots of material in so little time with such great fluency. You have 2 presenters, so I give you 2 questions. One is kind of an opinion I would like to get your feedback on. In my practice, giant hemangioma, it looks like a wastebasket. Anything like looks weird and wonderful gets dumped in that, and then a year later, we find out it's something else. Something I've found very helpful is that any enhancing component in a hemangioma should always be iso-intense to blood pool in every phase. So that's really limited to hemangiomas, and occasionally pileosis and the giant the epithelial hemangioma. I would like to get your feedback on it. And my second question is about the HCCs that pick up Eovis or Primovis. And Dr. Seelan has given us this great presentation in the Body MRI Valley workshop about that abbreviated MRI that uses out-of-magnet Eovis. Then you put the patient and you image in the hepatocellular phase looking for defects. And the pathophysiology that he informed us on was that HCCs lose their ability to pick up Eovis or Primovis much earlier than their ability to have neovascularity and arteria enhance. And that seems to be in a little bit of an apparent conflict with the 5-10% that start picking up the Eovis later. I just want to get your opinions about it, whether this is because of just genetic pleomorphism that happens later or...
Yeah, great questions. I can speak to the giant hemangioma question, which was a very good point. It's a very good point that you're right. I mean, it should follow blood pool in all phases. And we've, as I showed you, we had one of those cases that was misdiagnosed as a giant hemangioma, turned out to be neuroendocrine. What I've found is really if you have any kind of heterogeneous T2 signal, that evil gray T2 signal, you really don't want to be calling that a hemangioma. You just don't. And so I think for me, the T2 is really important. But I agree, you can oftentimes get weird enhancement even within a giant hemangioma because of the perfusional dynamics of such a large lesion, but the T2 is consistently off.
Yeah, thank you for your question. So for your second question, I agree with you. It might be confusing when you see uptake of Eovis or hepatobiliary agent on an HCC. So we don't use Eovis on a regular basis for our 6-month follow-up HCC screening protocols, but I'm coming from an institution that we actually formally use them. And in my experience, we never use abbreviated protocols similar to what other people are doing. Maybe that will be a way to go. Usually we start, in those cases, we usually start with a regular contrast agent and characterize every single lesion, and then follow up, make sure there's nothing that is growing on hepatobiliary phase. And usually in the couple of cases that we have seen, actually personally I've seen, they were very heterogeneous, and based on literature, the expression of these membrane receptors will decrease as they advance. So usually you're going to see an enlarging lesion, even on Eovis. So, and usually the ones that are showing uptake are not the poorly differentiated ones that start to metastasize. Usually they're moderately well differentiated, and they transform as they, obviously, like I cannot say, for example, they're extending from LR3 to 5, but during that process of hepatocarcinogenesis, they're actually progressing. So I don't think you lose much if you misdiagnose a small HCC, which is well differentiated and showing uptake on Eovis.
Thank you very much, both
Sure.
of you. Excellent.
Yeah, thanks.